Okay, so hi everyone, thanks for your patience. Sorry, we're having some minor technical difficulties on our end. Thanks so much for joining us for this webinar. We're excited to have this one. This was one that you guys identified as something you'd like to learn more about. So we're really pleased to have Dr. Reddy here to present for us. So quickly before we begin, I just wanted to show remind you guys of some of the functionalities of the webinar. So if you want to raise your hand to ask a question, we have a small enough audience today that we can definitely do that. So on your control panel on the left-hand side, you'll see a little hand icon. So if you want to ask a question, you can raise your hand and I'll be here moderating. This is Laura, and I can unmute you and you can ask your question. As always, if you have questions that you'd rather type in, you can use that questions box in the on your control panel as well. Just type your questions in and I'll try to get to them as we go through or at the end, whatever is most appropriate. So, and if you have any questions throughout or have any technical difficulties, feel free to send me a little message in there or send me a quick email and I can do my best to try to troubleshoot. So I'm going to pass it over to Dr. Reddy now. Great. You should be able to see the screen now.
Hello all, thanks for joining me today. It's Venu Corporate Day. I'm a concurrent disorder lead for Vancouver Acute and Tertiary here. Yes, it's a very important topic because obviously addictions, people with addiction problem have a lot of mental health issues and people with mental health also have a lot of addiction problem. So what I aim to do today is to give you a little bit of a background as to the extent of the problem, both internationally as well as Canada-wide, and then look at what might be a good models of care as to how to deal with this population. And also, depending on how much you want, I can talk about treatment recommendations and the best practices, and also what are the challenges when we are dealing with this population. So, I know that there's a very small sort of number of people today, but please feel free to stop me anywhere in the middle. If you got any questions, I will try to address as much as possible. Okay. I'm not affiliated to any pharma or any other agency, so whatever I have here is my research and what my experience. So just going back to the definition of concurrent disorder, as the word itself suggests, there's two conditions are going on together in one particular patient. So mental health as well as substance use. Quite often, they also have other physical health problems happening. It's truly multi-morbidity in some of this population. And there are certain countries, they use the word dual diagnosis, which also means concurrent disorder. But in Canadian term, if you use dual diagnosis, it's something with learning difficulties along with substance problems. So we really need to be careful when you're reading the literature, where the literature is coming from. I would say the comorbidity is probably much more better terminology to use, or co-occurring disorders that probably truly reflects as to what the condition is. As for DSM-5, we had a DSM-5 in 2013, which is a new diagnostic classification. We can find the concurrent disorder under substance-related and addictive disorders, or substance-induced anxiety, depression, or other mental health disorders. Let's look at prevalence of concurrent disorder. Here we're just talking about addictions and mental health. We're not talking about substance use prevalence. Substance use prevalence is a little bit, I'm sure you must have had a lot of talks around that. So I sort of try to move away from substance use discussion here. It's a more of, we're thinking about much more complex clients here, right? The data from National Survey on Drug Use and Health in 2012 from United States of America suggests 17.5% of adults with mental health illness. So we're talking about approximately 1 in 5 people with mental health have a co-occurring substance use disorder. As you can see, the prevalence of mental health itself is pretty high in the population. We're talking about anything between 20% of the population having some form of mental health issues. So in this 20%, more or less, we have 1 in 5 with co-occurring substance condition. That means both mental health as well as substance use disorder. The British survey, the United Kingdom survey, that's European survey, suggests that people with psychiatric disorders, 30% of them have alcohol dependency, 45% of them have drug dependency, whether it's marijuana or cocaine or opioids or other problems. If you look specifically at Canadian studies, there is a study which is done in Toronto. 40 to 60% of people, of adults with severe and persistent mental illnesses. We are talking about somebody with schizophrenia, we're talking about someone with bipolar illness, or we're talking about somebody with a major depression, having 1 in 2 or more of them have substance use problems. So it's a pretty much prevalent. The higher we go in terms of complexity of mental health, there is more substance use problems. And it's true for vice versa. It's true for people with complex or severe substance use problems have much more mental health issues, whether it's in form of psychosis or whether it's anxiety, post-traumatic stress disorder, or brain injury, or all those conditions. And there is a very interesting research around the prevalence of trauma or post-traumatic stress disorder among substance use clients itself. It's very high. Some of the statistics quote more than 50 to 60% of population, drug-using population, have some form of trauma or post-traumatic stress disorder. So why do people sort of use substance as well? People with mental health use substances, and people with substance have mental health issues. Why do they co-occur so often? So there are various hypotheses. One is called self-medication hypothesis, which means to alleviate mental health symptoms using substances. As you are well aware, 1 in 4 people, this is a WHO survey, most recent one from 2017, 1 in 4 have mental health issues, and out of whom 2/3 never seek treatment. So that is a pretty big chunk of people who never actually go and get help, mainly because of stigma or various other conditions. So the hypothesis is that they self-medicate with substances in order to deal with distress caused by their mental health issues. Next, a causal effect. Substance abuse increases vulnerability to mental illness. The typical example is somebody who is using crystal meth. It makes them more prone for psychosis, or more prone for paranoia or agitation. Similarly, those people who use marijuana before the age of 16, they are at higher risk of their psychosis happening quite early on in their life compared to people who don't use marijuana. So it's a causal effect as well. So substance use puts people at increased vulnerability to develop mental health issues. So there's also what we call it as a double trouble. It's an overlap of common or correlated causes or risk factors for both substance use and mental health. It's interesting if you look at some of the research from genetics and neuroendocrine or immune factors, there are a lot of common factors between mental health as well as substance use. So if someone has both mental health and substance use, they are much more troubled than them having one single condition. And some of the interesting research revolves around alcohol and why people with alcohol are much more prone for anxiety and depression. Then we talk about psychological causes. So both substance use as well as mental health causes trauma, feelings of alienation, that is loss of hope, and feelings that there is nothing else to lose, right? When both the factors are occurring together, these psychological factors are much more intense. Then there is a social factors and stigma. Like mental health in itself can cause family dysfunction. Substance use as well causes family dysfunction, and also unstable living condition. So when they occur together, it is much more burdening for someone with concurrent disorders. Right. So I just put in a graph here, right? In fact, one end is a mental health, the other end is addictions. So where mental health and addictions join together, it's a concurrent. In fact, in reality, that shaded area is much more bigger than what actually I put in there. the exact research, and things do change depending from country to country where you look at the research. But on an average, it's pretty confidently we can say at least 1 in 3 or 1 in 5 people with mental health use substances, or those with substances have underlying untreated mental health issues. So why do you need to treat this population? Why do you need to treat someone with addiction problem who have a mental health? Why do you need to treat them? Can't we just treat addictions and mental health will go away? Yes, it's true to some extent, but not always the full reality. So those people with mental health issues, with untreated substance use, or those with substance problem, untreated mental health issues, there are a lot of factors. Like it could lead to increased morbidity, whether the increased morbidity in terms of poor physical or mental health, or worsening of substance use in this population, and increased mortality. There's a much more higher suicidal rates among this concurrent population compared to those purely addictions or mental health. For example, those who use alcohol are at much higher risk of suicide compared to those just with depression or mood problems. Can you imagine joining alcohol and mood together? Then the mortality is much more higher. Then in terms of other problems, the disability, those who have concurrent issues have a much more higher disability compared to those either just the addictions or mental health itself. Then the social factors, there is increased crime, homelessness, and housing and instability. As you can see from some of your experiences in downtown population, this is much more prevalent, mainly because they're not only having addiction problems, they're also having quite a significant mental health issues. Quite often, they are untreated. So it's a very, very important in a facility where you're working, the patients with substance use problem are screened for mental health. The screening could be as simple as doing patient health questionnaires or generalized anxiety questionnaires, which probably takes less than 5-10 minutes. At least you know what is underneath these people, why they are not doing well, right? We also need to look at other important factors such as increased interpersonal conflict. It's going to be very challenging when both the conditions are occurring. In terms of it's going to increase their more issues with how they interact with other people. And also it's going to cause much more of a financial burden for them. And one more important factor I want to bring it to your notice is the cost of healthcare. There is a good amount of research is done when somebody comorbid condition is untreated. There is quite a substantial cost to the healthcare in terms of treating their condition. One of the research which talks about untreated depression or dysthymia. Dysthymia is a chronic form of low depression. If this condition is not identified and treated in substance use population, the cost to the service is almost 5 times more. It costs 5 times for the services to treat this population. So it's a very, very important. The conditions are identified and treated early on. Next. Okay, so it's well and good we want to treat these conditions. What are the barriers and challenges treating such population? If you historically go back to a number of years, how the treatments of addictions have developed, how the treatments of mental health have developed, they totally are in sort of 2 different silos. And depending on even the service delivery models follow those silos. The service delivery model by agencies, planners, or policymakers have been stuck in a single problem mode of thinking because of the long established barriers between the treatment systems for mental health as well as substance use problem. So it's been a historical, even now the service, how the services are set up is whether the patient is treated for mental health or for addictions. As I mentioned earlier, historically it's been 2 silos. There's a separate training for both the conditions, and there's totally a different fields how they are developed. And this became entrenched in the form of how the funding has followed the service, and also these administrative and policy structures. And the provided barriers. Providers perceive those with concurrent or co-occurring conditions as a much more complex and very difficult to treat. And the level of difficulties associated with and the use of integrated approach is one of the recommendations which is made. And people feel that using the integrated treatment is much more complex. So as a result, the providers itself, sometimes it's challenging for providers to provide that level of complexity, thinking that it's difficult to treat this population. And quite often, people with this two conditions, they run from pillar to post. They fall into the trap of emphasizing the primacy of one diagnosis over another in the acute situation, potentially making the situation much more complex to the patient. For example, somebody who has alcohol problems also has depression. The provider might well tell them, listen, go and get your alcohol problems treated first, then come back to us for depression, right? And if you see just somebody with alcohol problem itself, they find it very difficult to seek help. Forget about getting help. First of all, they need to go to the doctor or a provider to get help. If they have both the condition, depression as well as alcohol problem, it's going to be much more challenging. As a result, these people fall through the cracks. And the stigma, earlier we spoke about stigma. I know there's a lot of work going within the region here in Vancouver about how to deal with the stigma. It's a double trouble. The addiction itself is a big stigma. When you have a mental health, then we're actually dealing with two things here. Okay, so yeah, that's a little bit of a background. Now I'll talk about models of care for concurrent disorder population. And this is what I really want you to go away today, thinking that there are different models, how you or your service can look into these models and how you can help the population. Right. Historically, most of the models are based on addiction treatment. American Society of Addiction Medicine placement criteria. It talks about patient the needs and where they need to be treated. So the need could be whether the patient is ready for treatment or what situation is in terms of the relapse. So depending on the needs of the patient, they could fall into 6 different dimensions. The dimensions could be intoxication and withdrawal treatments. Number 2, biomedical, that could be that patients are probably going through distress and trauma, they need some support. Emotional and behavioral treatment. Next one is treatment, acceptance and resistance, relapse prevention or relapse potential, and recovery environment. So there are different dimensions each person with whether substance problem have and where they best need to be placed. Depending on that, the level of care is provided, whether the individual is treated in outpatients or inpatient facility or medically monitored intensive inpatient facility or medically managed inpatient facility. The medically managed could be your detox facility, Vancouver Detox, or sometimes going into St. Paul's Hospital or Vancouver General Hospital. So again, this slide is more of the different way of putting the previous earlier slide. There are 5 levels of care. And where they need to be placed. So one goes from outpatients to most intensive, sort of as you go down the levels or as you go up the levels, there is much more intense sort of input. Depending on how unwell the patient and patient needs are, they could be placed in each category. Now, we all talk about continuum of care for our substance using population. And again, American Society of Addiction Medicine, they talk about continuum of care being 0 to 4, wherein 0 and 0.5 talk about harm reduction and early intervention. Then as you go to 1, then we talk about outpatient services. It could be seeing a family practitioner in the community, or it could be just be a methadone clinic or somewhere. Then we talk about intensive outpatient. So it could be a community health teams, or it could be detox facility. Then again, under 2, there are different categories. It's 2 that's less intensive, whereas 2.5 is a little bit more intensive, and 2.1 is a little bit more intensive, and 2.5 is partial hospitalization. So all this again fall under outpatient or partial hospitalization. When you start going to 3 and above 3, again, we have a lot of subsets of continuum of care. That could be a residential facility or inpatient services, wherein higher you go, we have much more medically monitored. There's a much more medical input in that. And finally, we have 4, that is medically managed intensive inpatient services. Again, it could be hospitals or anywhere, but patient has a delirium tremens, or patient has much more complex withdrawals or other comorbid conditions, patient is suicidal or all the stuff, they fall into much more at a number 4 or more severe continuum of care. Right, okay. So probably I'm not sure how much you can see here on your screen. Now I'm coming to concurrent disorder model of care. So there are not many, there are different sort of models of care we talk about, but this is one of the simplistic model of care proposed by Richard Reese. He's one of the addiction psychiatrists from Seattle, from US. If you consider x-axis and y-axis, on x-axis on the below, we have mental health issues. The mental health issues, we say 0 to 10, that's a low intensity to high intensity. On y-axis, you have addictions, which range from low intensity addiction to high intensity addiction. Let's say we can divide this into 4 quadrants, wherein we have someone with low addiction problems and low mental health. They may well be treated in primary care. And then the quadrant 2 could be someone with high mental health issues. So somebody might be just sort of having schizophrenia. They might maybe smoking marijuana. So they could be treated in a specialized mental health teams. This community mental health teams are much more in a hospital outpatient settings. These sort of things fall under quadrant 2. Then we come to quadrant 3, specialized addiction clinics. So here we have people with high addiction problems, but still low mental health issues. They could be treated in a specialized addiction clinics or addiction facilities. Now, when somebody has much more high addiction problems and high mental health issues, what Health Canada, or a lot of research recommends, is integrated model of care for this population. And as we can see, most of our downtown population do fall under this high mental health and high addiction severity end. So they need much more intense services compared to someone who is having alcohol problems and seeing their family care practitioner. So what I'm saying here, not every patient with concurrent issues needs integrated care. Obviously, depending on their needs and where they could be best placed, and they could be treated in that area. Okay, so now talking about models of care for concurrent disorders, traditionally or historically, there are 3 different models of care. The first one is sequential model of care. Let's say again, I want you to think about in your mind an example of somebody who is having depression and also having opioid problems, right? So if you were to implement the sequential model of care to someone with opioid problems, so a system, how it will think is, let me treat his opioid problems first, and then we'll refer the patient to depression to somewhere else some other time. So the disadvantage with that would be having engaging an opioid client without any mental health itself can be very challenging. When somebody has depression or anxiety, they're much more difficult to engage or to challenge. So these sort of sequential care tend to fail in this population. And when you talk about difficult to reach population, we always need to start asking the question: are they having any other conditions why we are struggling to help them out? We're struggling to reach out. This is sequential model, so it is not something is recommended for this population. Next one is a parallel model. So under parallel model, basically you are treating both the conditions parallelly, but you're treated mental health under mental health umbrella, and patients get treated addictions under addictions umbrella. Again, the biggest challenge with this population is that they find very difficult to navigate the system. So it's very easy for them to fall through the cracks if they have to run around to get their care under different umbrellas. So the third model, which is recommended in this population, is integrated model. So it's a one team or one service provides both addiction and mental health under the same settings. Now we'll look at what are the components of the integrated model. So this is just an example of a parallel model. So we're talking about, when we say parallel model, getting mental health and addictions treated parallelly, but by different people. So here is a good example of how it can work, the parallel model. So obviously, you're not going to save the patient by doing this way. Okay, so I think probably I might have missed some slide here. I'm talking about integrated approach proposed by Drake and Musser. So the integrated approach has got a different components. And one of the most important components is a case management. Case management is basically assertively engaging the patient and retaining the patient in care. That's one of the most important aspects of a case integrated approach. Then closely monitoring the patient. So monitoring could be through close drug supervision and then talking to the patient about what's happening. Without having that close monitoring, it's going to be very challenging. And how often do you see the patient being checked for urine drug screen in mental health teams? This is not often, so it's very, very important we keep all this in the mind. Then having the substance use treatment and providing continuum of care services, what I talked about earlier. And then the patient needs to have a long-term support and rehabilitation to restore their social and occupational function. And pharmacotherapy, we should never forget pharmacotherapy, both for mental health, whether a patient has got schizophrenia along with opioids, they may well be treated with, having a good antipsychotic medications and engage them in opioid treatment. So pharmacotherapy forms a very important component of such therapy. Then the housing, quite often, and it's very, very important. Without somebody having a support or a proper housing, things are going to be very challenging for them to engage in any form of treatment, mainly because at the end of the day, if you don't have your basics met, then things are going to be challenging. So as you can see, there are different components for integrated approach, and more or less it does some way do happen in most of the treatment facilities we are doing. Like there is some level of case management goes on, and there is some level of close monitoring goes on, and there is some input with regards to medications and other treatments. But it's very, very important to look at this model as a biopsychosocial. Are we actually treating different needs of the population? And then this is a mnemonic sort of I came up with for the principles of integrated care. So the left side of your screen is the components of integrated care. These are the principles, right? Whether you're doing a case management or whether you're a doctor working in a team. So how to best engage these people? It's this is my own mnemonic. Feel free to use it. I sort of got it, and so it's called REACT, right? Having a responsible and flexible approach to this population, depending on what their needs, and responding to their needs, and slowly engaging them in treatment rather than you telling them what to do. And that next forms the engagement. And having access, whether it's a harm reduction treatment or when they're ready, and having the access to care. Whatever the care the needs are at this point in time is a very, very important component. And if the access is not available, they need to be referred to a right place. And continuous care is one of the most important component. And also training of the staff is important here, because obviously we are looking at both the conditions, not only mental health addictions, we are also looking at various other components of integrated care. So having this sort of a REACT sort of a model in your mind when you're seeing a patient who has a comorbid, as well as even I would say that challenging substance user, having this in mind is very easy to engage them and to have a better clinical outcomes. Okay, so I don't know how relevant it is in terms of me going a little bit detailed into treatments, but I will touch upon some of the treatment options, whether you're a doctor or whether you're a clinician or allied professionals. You can always have a better understanding. There are good treatment options. You can start having a discussion with your team or with your colleagues so that patient can be provided right treatment. Do we have any questions up until now in the models of care? I know that treatments, probably you are all familiar with most of the treatment. I really want you to sort of grasp the model of care concept, which I sort of talked about earlier. So I'll give a minute for anybody having a question around model of care. I always think that this sort of a model of care is not only for concurrent population. I also think that very challenging, difficult to reach out substance use population, this model can work very well. Okay, then I see there's not many questions there. Let me talk about treatments. If you look at the natural history of drug abuse, I know it's a little bit long slide. So you can think it in the pyramid sort of way, right? We talk about the treatments could be when initial use of drug of abuse, when somebody starts using cannabis or heroin or crystal meth or cocaine at the start, or experimenting it. So the most important bit is there's a large population who experiment, who socially use it, right? The most important thing for them on the top is primary prevention, and talking to them about probably the primary prevention probably is a little bit different here. Primary prevention in preventative medicine is basically working with population and prevent them from becoming cases. But in this case is more of talking to them about the harms caused by substance, and sort of more in the form of brief intervention. Then you have sporadic users, probably drinking alcohol or binge drinking on the weekends. So they probably, there are different types of treatments. But here, when I talk about pharmacological treatment, I think sporadic users, we still sort of opioids, sporadic treatments. Can we explore any other pharmacological treatments, like giving some relapse prevention medication to this population who are really struggling with the binge drinking, like naloxone or Camprol, these sort of medications. Sometimes in my practice, I do, if I have a sporadic user of opioids, if they're really struggling at times, I do use naloxone to help them with their use of the substances. Then we have a regular user, somebody who is drinking on a regular basis. Again, there is a scope for the medication and psychosocial intervention here. Now you have population, after a period of time, they have reached a stage of addiction, wherein they find very difficult to control their substance use, and the substance use is having a negative consequences in their various aspects of their life. Here, the medications have got a very important role here, whether you're detoxing somebody from alcohol or treating someone with an opioid problem or benzodiazepines. There is a good amount of research to say that if medications are provided early and if the withdrawals are treated well, the success rate is almost more than 80% in this population. At the same time, if you're not provided medications and if they're not treated well, the sustained abstinence in this population is less than 10%. So it's a very, very important to recognize that the medications do have a significant role in various conditions. I would say when you say various conditions, alcohol medications have got a significant role. Opioids, you all know that, have got a significant role in engaging them in treatment, and benzodiazepines and other conditions as well. However, most of these medications need to be treated in combination, providing some sort of a biopsychosocial intervention for it to have a much more better outcomes.
There was one question that came through about asking about what about the use of benzodiazepines for treatment of mental health diagnoses and those who are also on OAT. A significant number of our downtown East Side clients receive benzo prescription from their psychiatrist, while receiving OAT from a separate provider, despite the relative contraindication. Absolutely,
that's a very, very good question. That's something we all. Yes, there's a lot of discussion around, both with the college and how risky. There is a good amount of research to say that there is one very interesting publication from Veteran Administration, how those with how the opioid users who also have benzodiazepines in their system, their mortality is a much more higher. The data looked at those who are even used benzodiazepines in the past, but they're no longer on benzodiazepines. They basically, data looked at three populations. One population is just purely opioid users who are on opioid treatment. The other population is someone who was on benzodiazepines before, but no longer on benzodiazepines. The third population is currently on benzodiazepines as well as opioids. The graph is staggering, actually. If anybody look at the graph, then they change their mind. Even those people currently who are not on benzodiazepines, their morbidity and mortality is much more higher compared to people who are mainly on opioids, never been on benzodiazepines. Yeah, this is what we're all trying to sort of work on. It's a lot of work in progress. I know that's why when I spoke about integrated model of care, the service is provided by it's one team, so that service can be integrated much more better. So the most important aspect there is to engage the patient in optimizing their opioid users, and they need to be actively engaged in treatment of benzodiazepines. I think this is a very high risk population. Those who are on this, both the combination is very, very important. They are seen more regularly and they are treated, whether it's anxiety or depression, they are treated for their condition rather than having a benzodiazepines given to them. And is a big problem. I think it's a very, very important. Whenever you see this combination, the patient needed to be actively engaged in treatment, and the way to treat benzodiazepines obviously is why they have been given benzodiazepines, and if they are on a very high doses of benzodiazepines, it's a matter of them getting admitted to detox facilities so that they could safely be weaned off their benzodiazepines, or they attending a detox facility where the benzodiazepines are given a due consideration and they need to be stopped on benzodiazepines. Sometimes the client engagement can be very, very challenging because they're so fearful and frightened that their anxiety could get worse. So that's where we need a quite intensive medical input as well as a counseling input here, so that the cognitive behavioral therapy, other social psychosocial interventions can be helpful in this population. That's a very, very good question.
Maybe there was one sort of follow-up question to that about whether or not there are specific guidelines and evidence for the use of antidepressants for clients with substance use disorders.
Okay, so I'm actually going to, one of my slides, I'm going to come to that. I don't know how much time I have now. 20 minutes. Okay, so one of my slides has got I'm actually coming to that, and I'm going to talk about anxiety and antidepressants, and we'll take it from there. So, the issues, most of the research in mental health or addiction is done in this population. The population is very plain, either they have mental health or addiction problem. They have excluded this concurrent disorder population. The aim of any research is to produce a good sort of a study. And people, notoriously, the people with concurrent disorders, they fail to engage in studies and other things. So the result is that it could be very challenging to get the level 1, level 2, all the evidence in this population. But there are other issues as well. Prescribing in concurrent disorder or addiction treatment is much more complex. As you earlier mentioned about somebody who's having benzodiazepines as well as opioids. As you're well aware, people with opioid problems have a lot of anxiety, a lot of depression, a lot of other issues. And historically, they have been prescribed with various medications. So in this population, even if you want to give them a good amount of Suboxone or methadone, can be very, very challenging. So a prescriber quite often tend to sort of shy away from challenging some of the issues. Then the effectiveness of medication and polypharmacy itself. So what is the evidence base for prescribing antidepressants in concurrent anxiety and substance use? I will come to that slide later. I'll talk about it. Is there a role for benzodiazepines or Z drugs, I mean zopiclone or zolpidem, in anxiety management or insomnia in this population? So the effectiveness is very hard to sort of justify in this population. So the drug interactions, quite often, as you're well aware, somebody who's on methadone is also on trazodone, which is an sedating antidepressant medication prescribed for sleep. They're also on Seroquel, which is often prescribed for either psychosis or anxiety. They're also maybe using marijuana. So the drug interaction can be much more complex in this population. And as you're well aware, the more sedatives we have, the people are at high risk of accidental overdose. So I think this is a existing guidelines for Canadian clinical practice guidelines for anxiety management. If you look at here, these guidelines doesn't talk about concurrent. These guidelines talk about your standalone patient with social anxiety or generalized anxiety going to primary care practitioners or seeing a psychiatrist. These guidelines doesn't much talk about a specialist population of our downtown population who are very, very challenging. As you can see here, the first line treatment on the top is basically an antidepressant medication. Most of the antidepressant medications can be used as a first line for anxiety treatment. The second line is there are some benzodiazepines like clonazepam, diazepam, lorazepam. So these are the second line treatment. Quite often they are used temporarily to get the patient onto medication, and after a period of time they need to be stopped, right? If you look at top is a panic disorder. The second table 24 here is a recommendation for generalized anxiety disorder, which is, in my experience when I was working in that population, is a very, very prevalent. And interestingly, you don't have, if you go for second-line treatment, there is no clonazepam in this population here, but we do still prescribe clonazepam quite often. There is a role for diazepam to some extent. There's a role for alprazolam and lorazepam. Yes, I don't know if you can see that red sort of a box I put in here, recommendations for PTSD, post-traumatic stress disorder. There is no role for benzodiazepines here. If you look at second-line treatments, there is no benzodiazepines, but how often we find our PTSD patients who have trauma is being prescribed benzodiazepines in the community. So even with somebody just with a pure PTSD, there is no role, and you can easily justify them not going on benzodiazepines. This is the evidence for anxiety. One of the reasons why I'm saying is this is purely for anxiety, but if you actually look for evidence for someone with other comorbid conditions, substance use conditions, we can't, it's very hard to find a good literature to support prescribing practices. I got one more slide around that. What is best available evidence? I'll talk about it. So if you just look at anxiety as a feature of substance misuse, if somebody who is drinking alcohol, they often use alcohol to beat their anxiety, especially the social phobia or social anxiety. So alcohol is a very common means of self-medicating for somebody who has got issues in the social settings. Alcohol withdrawals itself can cause pronounced anxiety, and the long-term effect of using alcohol is either panic disorder or generalized anxiety disorder can come for alcohol. Then when you talk about stimulants or amphetamine, use of stimulant, people self-medicate with stimulants for social anxiety. And when somebody is intoxicated with stimulants, they have much more, the anxiety can get worse. And the long-term effects of using stimulant is, it can cause panic disorder, it can cause phobias, it can cause generalized anxiety disorder. And again, coming to nicotine itself, withdrawals of nicotine can cause pronounced anxiety. And coming to opioids, I think interestingly, opioids is one of those substances, except as when they come off the opioid withdrawals, the anxiety is not sort of, it can occur as a co-occurring, but opioid use itself doesn't trigger anxiety in the population, but opioid withdrawals can cause anxiety. The other interesting aspect is cannabis use itself in the long-term cannabis withdrawals and long-term use is associated with panic attacks and anxiety. Again, the literature in this area is quite disputed, and we need to learn much more around cannabis and the association with anxiety. Okay, so what happens in terms of prescribing? I just put in on the top cannabis, opioids, and alcohol. So a prescriber need to be very careful when somebody is using cannabis, when they're prescribing other medications. So one of the most important things we need to preach is that when somebody is already using other substances actively, trying to aggressively treat them, they need to be closely followed up to see what's happening. Because, for example, if you prescribe antidepressants to someone who has cannabis problem, as well as having anxiety, it can worsen their tachycardia. It sometimes can make their anxiety worse. And prescribing benzodiazepines to someone with cannabis problem, it can increase the level of sedation. And prescribing antipsychotics such as quetiapine or other antipsychotics to deal with anxiety in cannabis population, it does increase the risk of sedation. Now coming to the methadone and heroin, people who are on opioids and other problems, then opioid, methadone or heroin itself can actually produce significant amount of sedation and respiratory depression. When you prescribe antidepressants to this population, we need to be cautious about avoiding any sedating antidepressant medications. So some of the non-sedating antidepressant medications are SSRIs, which are first line, like Prozac or other medications should be a first line of choice for this population so that they don't develop respiratory depression. In terms of earlier question we talked about benzodiazepine use among heroin or methadone use population, they're notorious for causing respiratory depression, and it can cause accidental overdose. And there is also a pharmacokinetic interaction between these two medications, especially those on methadone. It can actually increase the levels of methadone in their system. So the combination of opioids and benzodiazepines together can cause much more problems than just sort of using one drug. And Other biggest problem, I don't know, you in downtown East Side and other places, you see a lot of people who are on methadone and opioid treatments also being on a sedating antipsychotic medication such as Seroquel, whether it's a low dose or very high dose. Again, there is a risk of additive sedation in this population. So sometimes there is a case reports of methadone withdrawals being precipitated by use of risperidone. And also one more thing I would suggest in terms of positive fentanyl, positive fentanyls in opioid population, we are seeing in inpatient facility risperidone can or paliperidone can give false positives for fentanyl. So you need to be very careful with that as well. Somebody who is on a risperidone or paliperidone depot or injections or tablets, it can give a false positive for fentanyl. Now coming to alcohol itself, again, alcohol is a sedating drug, and any sedating medication can worsen the sedation levels and also can increase the risk of respiratory depression in this population.
So I just had one question come in from one of our GPs, and he's asking for your thoughts on stimulant treatment for ADHD in the context of substance use disorder, and then stimulant use disorder or opioid use disorder in particular. Okay, I think I will come to that. I will try to focus on that in the last few minutes of it. It's an interesting area. Yes, that's a very, very good question. I will come to that. Okay, maybe I'll quickly sort of flip through this thing and maybe leave 10-15 minutes for question and answers. So somebody was asking about how do you treat depression in this population. If you got a depressed alcoholic in your population, using a traditional SSRIs, which we tend to use as a first line, tend to worsen the drinking outcomes in this population. As I said, there is no specific research done in this population. This is more of a secondary analysis of the data. What the evidence suggests is a much more better to use older form of antidepressant medications such as tricyclic antidepressant medications or mirtazapine in this population, which can improve mood, anxiety, as well as cravings. But one risk of using tricyclic antidepressants, if you don't follow up the patient closely, somebody who, if they are at risk of an accidental overdose or suicidal risk, they could potentially use tricyclic antidepressants, and it could be quite dangerous in this population. So you need to be pick and choose who might do well with tricyclic antidepressants. Again, if you've got a depressed opioid user, SSRIs, the first line medications, are very good, and also the tricyclics again are much more helpful in this population. But you need to be careful because tricyclics are there are sedating medications. So if somebody is on very high doses of opioids, then it's better to go for a SSRIs as a first line. Then you have anxiety and alcoholic patient. Buspirone is one of those medications which could be used in this population. Then you got a social anxiety and alcohol. Again, paroxetine or other SSRIs are beneficial in this population. And you got a post-traumatic stress disorder and alcohol patient. The first line of post-traumatic stress disorder is using sertraline or one of the SSRIs. But experience and the research suggests that sometimes the SSRIs can worsen the drinking outcomes in someone with PTSD. So again, the combination of using tricyclic antidepressants along with anti-craving medication called naltrexone is much more helpful in this population. Okay, so anxiety and alcohol use disorder, if you don't treat anxiety, the chances of them relapsing is much more higher. Those with persistent anxiety. So it's very important you identify and treat the anxiety in this population. And anti-craving medications are pretty good in this population. Once the detox is done, like Camprol, baclofen, have shown some benefit in reducing the anxiety. And also, I'm pretty sure that you all must be using gabapentin in this population. Again, although there is research is minimal, but it's not a bad idea to try using gabapentin to maintain the relapse prevention. PTSD population, naltrexone or antabuse are pretty good, those with anxiety and alcohol. And you need to be cautious about using sertraline, which is a first-line treatment in this population. Okay, I got 7 more minutes. So opioid and depression, I think depression is common in the opioid-using population, and they do equally good as non-depressed patients if they are treated well. And in this population, using a good doses of methadone or Suboxone and engaging them in treatment has much more better outcomes. And there is a certain receptors with Suboxone, like kappa receptors, are
are showing a very promise in the treatment of depression. So we might see a low dose of Suboxone might be helpful in someone with depression as well in the future. Depression, despite of treatment, can persist in 10 to 20% of the population. Okay, so you all must be familiar with the relapse prevention sort of strategies, pharmacotherapy for relapse prevention, along with your psychosocial interventions. So someone with depressed alcohol patient, if you want to maintain them in recovery and relapse free, using naltrexone along with the good dose of sertraline can be effective in this population. The depressed opioids using naltrexone is helpful to improve their mood. These are people, again, who are actually recovering, not on any treatments. So PTSD and alcohol, using treatment, naltrexone can improve the drinking outcomes. Then anxiety and alcohol, baclofen, and camprosate is known to have a positive outcomes. So yeah, just now going to ADHD and answering one of the questions, ADHD, and we're talking about stimulant use. Yes, people with stimulant use disorder have high rates of ADHD in them compared to a non-stimulant population, and those with ADHD do have high rates of comorbid substance use as a self-medication hypothesis. So I think one of the most important aspects, yes, they need to go through a proper assessment, and assessment should involve a developmental sort of a good developmental history with a diagnosis of ADHD as a child and what happened, and when the substance use came later in their life. And they need to, I think they're the very good candidates for integrated treatment. So yes, you could start with using a second-line treatment such as Wellbutrin or Strattera in this population. Quite often, my experience suggests that they don't do very well. But using using medications such as Vyvanse, which is a long-acting dexedrine, is known to have a much more better outcomes. That's what I tend to use when I have this population in my practice. And also methylphenidate, long-acting methylphenidate preparations such as Concerta could be quite helpful as well in this population. The trick is daily pickups or daily witness could be done in this population until they are stabilized and stable, and need to get a regular urine drug screens and do a good documentation so that the outcomes are better. And using ADHD rating scales even at the start before they go on to treatment and during the treatment also give you a good indication as to how they are doing. So I would strongly recommend using medications to treat ADHD in stimulant population. Next, okay, so going back to, okay, so I think I'm missing something here. Yeah, so as you say, the addiction itself, treatment of this population itself is a complex intervention. So it needs the case management in the center, the housing needs to be dealt with, and medications need to be dealt with, and the psychosocial interventions are very, very important, and follow-up and recovery. So one of the strong emphasis I could suggest to you is whether it's addictions or concurrent problem, it's a chronic disease. It's a chronic disease like your hypertension and diabetes, and patient cannot be in the treatment or a detox facility or other places just for a week or two and they're going to get better. So they need ongoing care along continuum of care, and they need ongoing support for them to have a much better outcomes. Thank you very much. I will take your questions.
So we had one question that came in that asked, said it was great to see the different models of care, and a question about how we're doing in BC with regards to those models of care.
Okay, that's an excellent question. So it's, I think we do have, we can place some of the services. I can give an example of Vancouver Coastal Health, how we could place different patients under different thing. Obviously, quadrant 1, primary care. We're talking about population with low substance and low mental health issues. Then probably we have quadrant 2 with mental health issues, treated in a community mental health teams and other mental health services. And we have various integrated teams in downtown east side and other places. So they're probably trying to deal between, I would say, quadrant 3 and quadrant 4. When we come to much more intense population of substance, both severe substance and mental health, we have ACT teams We have Burnaby Center of Mental Health and Addictions and other higher levels. We are doing well, but we can do better. There could be a better integration between one service and other service so that a patient finds the journey easier. Quite often patients are quite confused in a way how they can travel from one system to other system. I think there are a number of services, but we can have a much more better clarity to our patient how they can navigate through the system.
So any final questions? We're just have about 2 minutes left. So if anyone wants to put up their hand, if it's quicker to ask live, or you can chat in any final questions. If you have any questions after we leave the webinar here, you can send them to me.
Absolutely, yeah. You can always send. You can send it to my email. I'm more than happy to sort of answer those things back. I know it's an ongoing discussion. I think we all the models are evolving. The scope in Vancouver itself is changing quite significantly with whatever the crisis is happening. I'm sure we can all sort of make our own regional and local model to help our population.
Okay, great.
Thank you all. Thanks for joining me today.